I'll divulge a little secret about myself. I have two personalities. Yesterday you saw the ebullient Steve Phinney talking about the amazing things you can do with a ketogenic diet and inflammation. Today you're going to meet the grumpy old internist, Steve Phinney. And so now I also want to absolve Dr. Gerber and Dr. Taylor for my being here to present this talk today, because they didn't ask me to give this talk. I insisted that if I came here and gave the other talk, I also get to give this one too. And it's a little bit painful, and I hope that I won't offend too many people in the audience with what I want to tell you, but I view fasting as a dual-edged sword. There's a very sharp front edge of the sword that you can use for mobilizing fat, losing weight, increasing ketone levels, and the benefits of autophagy and all the other things that we're learning about the effects of fasting. But I have seen in a number of instances in my career the sharp backside of the sword, and that's what I came to talk about today. So it isn't that the others don't exist. I want to keep this in perspective and establish maybe a little bit more balance than we've seen in some of the presentations on fasting previously. So by way of disclosure, the conflicts of interest I mentioned yesterday, nowhere in here do I get any income from fasting. There are many definitions of fasting, and I want to focus mostly on the highlighted area here. I understand there's a lot of information on benefits of partial day fasting, but there aren't that many studies that show dramatic effects. And particularly, I want to focus on longer-term effects, not just short-term effects. Single-day fasting, again, I'm agnostic on this. The research is, I think the really good research is in the process of being done in terms of large, well-controlled cohorts. Skipping over to 5.2, the question that I have is, are those 2 days together, simultaneous, and is it true fasting, or is it just reduced energy intake on those, quote, fasting days where people eat much less food on those to be substantially hypocaloric? But the area I want to focus most on is multiple day fasting, and my definition is more than 48 hours of going without eating any calories of any form. And there are a number of discussion points I want to focus on in this brief talk. So the first one will be the effects of fasting on metabolic rate. Now, I'm going to apologize because I can only show you old data. And the reason is that the data that was done in the past has stood the test of time, even using more antiquated measures of determining oxygen consumption and CO2 production, or even direct calorimetry, where you actually measure the heat production by the body. Those results that were produced before 1980 have stood the test of time. So this is a composite diagram that was published in 1991, and this is a composite of multiple individual subjects being studied over periods out past 30 days. And this shows the basal metabolic rate as percent of the predicted value based on the Harris-Benedict equation, which was published in 1919. So this is antiquated data, but as I said, it stood the test of time. And what you can see here is that when you look at the change in basal metabolic rate, that as you get out past 5 to 10 days, there is a substantial reduction in basal metabolic rate and total energy expenditure analogous to that. And the value when you get out in the range of 30 days, you're down to about a 25% reduction in resting metabolism, which is a very substantial reduction in resting metabolism. In the yellow highlighted area up here at the top, in the first day or two, there's actually, in some studies, particularly done in lean people, there is a bump up in resting metabolism. And that's due to the catecholamine response that's needed to stimulate gluconeogenesis. And so you actually have a brief uptick. And so I've heard people say, well, fasting increases your resting metabolism. And I say, yeah, for 2 days. And then what? And I think that's an important observation. So that was a summary of very old data. This is a study published by a German group in 1981. And what they compared here was total fasting to protein supplemented fasting, a very low calorie ketogenic diet. And these are differentiated substantially in terms of the effect on resting metabolism. And as you can see in the highlighted sentence here, basal metabolic rate showed a significant decrease, 25%, during total fasting. And this was for a period of 30 days. So there is this body of data that has not been refuted by, let's say, countervailing science. So I don't believe I'm cherry picking the data when I present this to you. So we try to put it into just a simple composite diagram. And if you look at it here, in the early initial few days, you can sometimes see an increase in resting metabolism, but then a long progressive thing that goes out past 30 days, where the body is becoming increasingly conservative with its calories as its energy reserves are being depleted. And this is not protected very much by adipose tissue. It's protected a little bit by adipose tissue, but having excess body fat doesn't protect your body from this decline in resting metabolism. And then the other question that has not been answered in a well-done prospective study is, okay, if it goes down that much in 30 days, and then you stop fasting, how soon does it come back up? I mean, that would be good to know. And I don't know of any paper that studied that in a prospective way. In a kind of perverse way, we do have some data on that. And that was from this really unfortunate experiment called the Biggest Loser study, where obese people who were induced to do absurd amounts of exercise and extreme caloric restriction in order to get the most rapid weight loss possible. And to the credit of some people, they decided they'd study them, not just while they were doing it, but follow them up on them. And there's this reference by Fogergill here, published in Journal of Obesity last year, in which they looked at the effects of this on resting, this experience on a group of these people on resting metabolism 5 years later. And when they did careful body composition analysis, so they measured lean body mass, and lean body mass has the highest correlation with resting metabolism across individuals. But when they took the same individual and took a kilogram of lean body mass before they went through this extreme privation and excessive exercise, they started out at 34 mils of oxygen per kilogram body weight per day at baseline. And 5 years later, even though they regained much of the weight, their resting metabolism was 27. So that's a 20% persistent reduction in resting metabolism after 5 years. So if you think this is a transient effect in everybody, maybe it is a transient effect in some people, but in these people, this was not transient. This was permanent metabolic damage. And I'll just put it in those terms. This is a grumpy old intern who's talking. So now let's talk about nitrogen metabolism, because lean body mass is an important determinant of well-being and function. And losing lean body mass is seldom a good thing. Losing fat mass, probably a good thing. If you're a bodybuilder who decides to run a marathon, yeah, you should lose some lean body mass if you want to run a marathon. But why would you want to go out and run 27 miles anyway when you can do it in a car in a short period of time? So let's talk about, first there's a little lesson here in protein turnover. And I took a graduate course in protein metabolism. It was a whole semester at MIT, so I'm going to try to make it a little simpler for you. But if you just think in terms of what determines how much lean tissue you have in your body, part of it is how much protein is coming in your mouth. So protein intake is an important component. Let's just say somebody's eating 100 grams of protein. And if they digest, metabolize that protein, and then excrete the equivalent amount as, quote, nitrogen, that 100 grams of protein is turned into about 16 grams of elemental nitrogen, which comes out of the body in multiple forms when we're in a fed state, mostly as urea. And so if you have 100 grams of protein coming in, 100 grams of protein going out, day by day you maintain the same lean body mass, which is probably a desirable thing in most states, unless you're a bodybuilder trying to be better than Arnold Schwarzenegger or something. But the interesting thing is what's going on in the middle, this what we call protein turnover. That when protein is digested, it's broken down to amino acids. They enter the bloodstream, and those entering amino acids can be used for protein synthesis. But at the same time that you're eating 100 grams of protein, your body is typically breaking down 400 grams of protein. And using the 100 grams that comes in, it's synthesizing 400 grams of protein. And then you have the equivalent of nitrogen equivalent of 100 grams coming out. In the meantime, you've got 10 kilograms of of protein in your body. This is the, quote, average typical 70-pound, 5 foot and 10 inch male kind of thing. So if you look at it, there's 1% of your body protein content is coming in each day, 1% is going out. So you think that's a pretty small amount. But if you stop the protein coming in, you don't stop the turnover. And so the excretion tends to continue. And so that leads to what we call negative nitrogen balance. And I want to talk about that. The classic studies in this were done by George Cahill's group at the Joslin Research Foundation in the 1960s and published between 1960s to about 1975. And then Cahill went on and kind of summarized this in multiple review articles. And so this is a figure taken from one of those review articles. And this shows the 15 or 16 grams of, this is urinary excretion. And there's another gram that comes from skin and hair and things like that coming off the body. So this is the 16 grams of breakdown product coming out in a normal state. And then he says, and in starvation, it comes down dramatically. So you can see there's just a little bit of urea, some ammonia, and other things like creatinine coming out in the urine. And you add those up there, about 5 grams per day. But this data has been misquoted at times where people say, look, the urea content is less than a gram. So actually, when people are fasting, they're not losing lean tissue. But I'll point out that this is not the first day of fasting. This is after 28 days of fasting, after the body's had a prolonged period of time to adapt to protein deprivation. And it does that very effectively. It cuts this protein breakdown from that turnover by a factor of 4, but it takes 28 to 30 days to achieve that. In the first few days, what happens? So this is a graph that was put together by Jill Forbes and Drenick. And this was from multiple studies that they had done, and it shows nitrogen and weight losses in lean people, and those are the dashed lines here who are on total fasting. So lean people lose nitrogen and weight actually faster than obese people, which are these two lines, weight and nitrogen. But being severely obese doesn't protect the overweight person from this early rapid loss of nitrogen. The adiposity reduces the rate somewhat compared to a guy like me going on a fast, but not by very much. And there is a slow attenuation of the rate of loss, as you can see here. And is that an isolated observation? Has that been refuted by others? Well, there are multiple classic studies. Here's one on 72 lean and obese women fasted for 7 to 28 days. This is published by a German group back in 1975. And again, what they point out is that fasting men lose faster than women. Women are a little bit more conservative in terms of how they manage nitrogen, but both lose between 1/2 pound and 1/3 pound of lean body mass in the first week. So the most rapid losses are after the first few days. So when I say, well, I'm not too worried about the first few days, but after that, that's when you start to feel the backside of this sharp sword. So one other study done by some surgeons looking at whether you can mitigate nitrogen losses by infusing a deaminated version of a branched-chain amino acid. We'll ignore that, but this is the loss that they saw in terms of urea nitrogen in the first 14 days of fasting. You see, the people adapt very quickly, but the losses are greatest at the start. And you say, well, that's only 10 grams. Remember, there's typically 4 other grams of nitrogen besides urea that's being lost, so that takes it up to 14. Multiple studies, and I do not know of any studies that countervail this. So I've done my best not to cherry pick the data when I present this. Mineral issues. You heard just a superb presentation yesterday by Andrew Mente on the role of sodium, and he didn't get much into potassium, but implicated that that's also extremely important. And when you're fasting, there are 2 things that are going on. One of them is there's something called the natriuresis of fasting. And natrium is the Latin term for sodium, and it's accelerated sodium excretion with fasting. And this is a very robust observation, and it's been very well characterized in humans and in dogs. Dogs make superb analogs for humans in that regard. And this, when you're going to nutritional ketosis, the body doesn't conserve sodium; it accelerates sodium excretion. But if you're totally fasting and you're not consuming sodium, you're going to be depleting sodium, which is mostly in the circulation and extracellular fluid. When that contracts, renin is released from the adrenals, aldosterone goes up. Aldosterone is a damaging stress hormone, and that subsequently leads to cortisol increases. And the other thing that aldosterone does is in order to try to cling to sodium, it makes the body waste potassium. So you get this double whammy of shrinking sodium volume and losses of potassium. So even if it's a few days, on those few days when you're fasting, those are days when you're not getting in sodium and potassium, and you're basically building a deficit that need to be repleted after the fast, whether it's a 2-day fast or a 1-week fast. And then also magnesium is lost as you lose lean tissue, and if you're going to gain back that lean tissue, it's going to require greater magnesium intake beyond the normal required level to achieve that. So whether it's intermittent fasting, where you have a few days of deficit per week, those days of deficit have to be made up with your diet in the intervening days, which means that the nutrient density of minerals in the diet needs to be not just adequate, but superior. And we very seldom take that into account. And then, again, grumpy internist, I write prescriptions for medications. I want people to take them consistently. But what happens when you fast if you're on medications for diabetes? And interestingly, there was just this paper published, I think, last week, looking at intermittent fasting and effect on risk of hypoglycemia in a randomized controlled trial. And these were people who were fasting either for 2 days intermittently or 2 days consecutively during the week. And you can go and look at the reference, but what they found was even though they withdrew or reduced medication on the fasting days, so they told people if you're going to fast, reduce your medications, they still doubled their risk of symptomatic hypoglycemia. So when you're on a medication to control blood glucose and you markedly cut or dramatically change your carbohydrate intake from day to day, you're going to get onto a roller coaster ride. And that's a risk. And finally, I'm thrilled Dr. Bickman mentioned refeeding syndrome, that this is something that I was not taught in medical school, but I learned it in clinical practice because much of my practice when I was in academic medicine, teaching and practicing nutrition was I was doing in-hospital nutrition support with intravenous feeding, TPN. And when you take a patient who's been fasting, they get transferred from a hospital where they didn't do TPN, this was back in the old days, and they came to our center where we did do TPN, and the surgeons would tell the pharmacist, start him on TPN, and the nurse and the pharmacist would put him on TPN with high glucose and the normal amount of phosphorus, magnesium, and potassium. We would oftentimes see profound reductions in the blood levels of potassium, magnesium, and phosphorus, which can impair respiratory and cardiac function. They say, hey, the guy looked pretty good. We put him on TPN, and now he's on the ventilator and comatose. What happened? And this guy's phosphorus level's 1.0, and it should be above 2.8. And that's refeeding syndrome. How was this discovered? This was discovered when people were rescued from lifeboats or rescued from situations of prolonged starvation, and to be nice to them, they gave them copious amounts of food. When you're fasted and then you suddenly feed, particularly with carbohydrates, and you put a lot of glycogen into a glycogen-depleted muscle, potassium, magnesium, and phosphorus have to shift out of the plasma into the muscle, and you create at least oftentimes profound transient blood levels, lowered blood levels of those key minerals, and you can put a person into coma, heart failure, and even kill them by doing this. And it's something that should not be ignored. And after a prolonged fast, someone really needs careful dietary and medical supervision through the feeding period. And just telling the person, as is quoted in one popular book, just don't binge, I don't think is adequate respect for this dangerous situation. So the summary is, early and ongoing lean tissue losses are not minor, that there can be prolonged reductions in resting metabolic rate, and the longer one fasts, the greater the reduction goes down, and we don't know how fast or what the individual variations for people in recovery of this important metabolic parameter. That one of the behavioral problems with intermittent fasting is that if you do it 1 day a week and you get some benefit, and then that tapers off and you want to get more benefit, then you do it 2 days, and then you say, well, I'll try a 7-day fast, and you end up with a law of diminishing returns. And people want to keep this line going down straight by doing more and more extreme efforts. And that's the slippery slope. And we should stay away from that. And I already belabored the issue of refeeding syndrome, and I'll quit there. Thank you much.